The goal of this presentation is to give you a better insight into exactly what musculoskeletal ultrasound is. If you were to search the literature for information, you might find several synonyms. For example, echography, sonography, ultrasonography, and ultrasound. These words all describe the same thing: the medical imaging technique that is capable of visualizing soft tissue structures in order to capture their size, structure, and function with real-time imaging. In this course, we will use the word ultrasound. There are different fields of ultrasound, each one looking with its own view at the human body. Two examples are cardiovascular ultrasound, which looks at the heart or the blood vessels, or abdominal ultrasound, which looks at the internal organs. Since you have an interest in the musculoskeletal system, you're about to learn the theory of musculoskeletal ultrasound. The transducer or probe is an essential element of the ultrasound equipment, responsible for the generation of an ultrasound beam in a certain megahertz frequency. This beam is sent into the body and goes through various soft tissue layers like skin, fat, muscle, and tendon. Each soft tissue layer will reflect a part of the beam back to the transducer. Bone is hard and can't absorb an ultrasound beam, so the bone will reflect all that is remaining of the acoustic beam. The transducer detects the returning echoes and sends the signal to the ultrasound system, where all information is processed by the software. After processing, the image can be seen on screen. The whole process of sending, receiving, and processing happens so fast that there is no delay. All structures can be scanned and visualized in real time. Let me show you a few examples. In this slide, you can see an ultrasound scan of the upper leg. A transverse view of the femur and all four quadriceps muscles can be seen. Each muscle belly is covered by bright white fascial structures, the epimysium. On top of the four quadriceps muscle bellies, we can see a horizontal dark zone, which is the subcutaneous fat. Here you can see an ultrasound scan of the ventral infrapatellar region, showing several types of tissues. See the yellow arrow pointing at the following anatomical structures: the patella, tibia, at the bottom left the femoral condyle, hyaline cartilage of the femoral condyle, Hoffer's fat pad, and between the white arrowheads and the yellow arrows, the patellar ligament. This is an example of a nerve, to be precise, the median nerve in the carpal tunnel. The median nerve can be seen on top of the white-coloured flexor digitorum tendons. With ultrasound, one can observe the median nerve both statically and dynamically. Musculoskeletal ultrasound is the preferred imaging technique in extra-articular soft tissues, like, for example, muscle, tendon, fat, fascia, arteries, nerves, ligaments, bursas, and cartilage. Capsular problems can also be assessed using ultrasound. However, ultrasound is limited in this instance. Intra-articular structures are difficult to assess with ultrasound, and in fact, most of the time, it's impossible. So, what equipment do we need for musculoskeletal ultrasound? First of all, we need a transducer. Transducers come in various shapes and dimensions and are designed for the body parts they have to assess. For musculoskeletal ultrasound, we generally use the straight, linear transducers. The transducer is connected to the ultrasound system. There's a big variety in ultrasound equipment. There is a variation in price, size, and portability, quality, and functionality. Some have a touch screen, other systems have buttons. The ultrasound systems commonly used in primary care are mainly the laptop systems as seen on this slide. It provides the healthcare professional with a relatively affordable, easy to use, portable system. The ultrasound systems commonly used in secondary care are generally bigger in size and better in quality if scanning more complex and detailed anatomy. These systems are also more expensive as quality comes with a certain price in ultrasound. There are cheap systems available on the market, much cheaper than all the systems shown in this presentation. However, both diagnostic accuracy and clinical usability are much lower with these cheaper systems. Over the last few decades, ultrasound systems are being used with more or less success. This is an ultrasound system from the 1950s and one from the 1960s. Fortunately, ultrasound technology is rapidly advancing and being refined. This has resulted in the recent development of smartphones and tablets that can be used for ultrasound assessment. It's just a matter of downloading an app to your device, connecting a transducer to your device, which contains all electronics necessary for ultrasound, and then you can start scanning your patient. Here you can see that there are also developments in wireless transducers, not only for the smartphone solutions, but already existing for the systems currently used in clinical practice. Smart device-based ultrasound devices are innovative with interesting pricing and an interesting future. The quality among these systems differs quite a lot. The general quality is good enough for the bigger anatomical structures and all bigger pathologies. The devices still have limitations if it comes to smaller anatomical structures and/or smaller pathologies. Our worries are not about the device itself. We feel that the device is a big step in the future of mobile scanning with a smart device. Our worries are more about the professionals using it, that they will overestimate the device and will perhaps make definitive conclusions about clinical matters for which the device is not yet suitable. Always know your own and the device's limitations. Musculoskeletal ultrasound is a fantastic tool which will improve your skills and knowledge. It brings more patient satisfaction, and it's a good business opportunity when used in a qualitative and patient-centered way. Therefore, we recommend spending or investing a little bit more on a new or refurbished system, because in the long run, this will definitely pay off. The goal of this presentation is to compare ultrasound with other assessment techniques, such as MRI and arthroscopy. If we're going to assess the musculoskeletal system on a structural level, we can choose several medical imaging modalities, like for example ultrasound, MRI, X-ray and CT. According to Tan et al. And many other articles, ultrasound and MRI are the most interesting techniques for the imaging of soft tissue structures. Let's have a look at the advantages and disadvantages of ultrasound and MRI. In terms of cost, ultrasound is much cheaper than MRI. Ultrasound is not only cheaper to purchase, but it's also much cheaper to use. The ultrasound system itself is of course an investment, but once you have it, you will only incur some electricity costs, and perhaps you might want to update the software after a few years. When considering the increasing healthcare costs, the low cost of ultrasound makes it an interesting modality to reduce the burden for both society and the health insurance companies. The low price also makes it an interesting business opportunity. Ultrasound is much more accessible than MRI. In many cases, ultrasound is also portable, so you can take the system with you to your patient or client if needed. Or you can easily maneuver the ultrasound system around the patient on its trolley. Once using it, you're not only limited to the area of initial interest, as you are with MRI. If you're performing an ultrasound exam of the shoulder, and during the exam you think it might be an elbow problem, you can very easily move from the shoulder to the elbow within a second. This is not possible with MRI. The most important advantage of ultrasound compared to MRI is the possibility to make functional real-time scans. Combine the clinical examination with the musculoskeletal ultrasound as much as possible, and see what actually happens with the soft anatomical tissues during movements and provocations. This very functional assessment improves diagnostic accuracy and clinical relevance. Both MRI and ultrasound are very safe methods of medical imaging without any damaging or ionizing radiation. you can always use musculoskeletal ultrasound. However, in some cases, we suggest to work with the ALARA principle when scanning with ultrasound. ALARA is an abbreviation for as low as reasonably achievable, meaning that there are no contraindications, but in certain cases, it's better not to scan that particular region more than is medically absolutely necessary. This applies to, for example, malignant tumours, bone fractures, and pregnancy. The only disadvantage of ultrasound compared to MRI is that ultrasound is highly experience dependent. So ultrasound is difficult to standardise. It has many possible equipment settings and requires lots of experience and practice. Please realise that ultrasound is not profession dependent. All musculoskeletal healthcare professionals can learn musculoskeletal ultrasound as long as they meet certain criteria. These criteria will be explained in another presentation. The advantage of musculoskeletal ultrasound compared to an arthroscopy of a tendon, for example, is that with ultrasound you can see the status of the internal architecture. This is of course not possible with an arthroscopy. Patients actually prefer ultrasound examination to MRI. They say that MRI is very loud, it requires that you're not claustrophobic, and you're not able to move during the exam. Furthermore, it requires the removal of metals and makeup, etc. In general, ultrasound is regarded as being more patient-friendly. The first important key message of this presentation is that you should not make any hard statements, not to patients and not to colleagues, until you have sufficient experience. Research has shown that you have to make at least 100 to 200 scans per anatomical tissue before the diagnostic accuracy is satisfying. 200 scans sounds like a lot, but if you scan this particular tissue 20 times per week, then within 10 weeks you've met the criteria. If you only scan 4 times a week, it will take you 50 weeks, almost a year. So practice, study and learn, preferably on a daily basis. Ultrasound is a wonderful adventure which will enlighten you more about functional, three-dimensional anatomy and biomechanics. It will make you smarter and more critical. You will know much better what you can treat and what you can't treat. Your success rate will increase because you will only treat those patients who you can actually help. Lifelong learning is essential in musculoskeletal ultrasound. The goal of this presentation is to explain the diagnostic value of musculoskeletal ultrasound and its influencing factors. If you perform a clinical test, like a clinical examination test or musculoskeletal ultrasound, you're interested to find out which patients actually have the disorder and which patients don't have the disorder. But with every test, some patients will test falsely positive or falsely negative. Therefore, it's interesting to know the sensitivity and specificity of a certain test. Sensitivity of a diagnostic test indicates the test's ability to detect those patients who actually have the disorder, as indicated by the reference standard. Specificity of a diagnostic test simply indicates the test's ability to detect those patients who do not have the disorder, as indicated by the reference standard. In this table, you can see the musculoskeletal ultrasound values of sensitivity and specificity. Musculoskeletal ultrasound generally has a high diagnostic value, equal to that of MRI. Because it's important to understand the diagnostic value of ultrasound, we'll have a closer look at the statistics in a few minutes. After that, we'll present the influencing factors of clinical practice on the diagnostic value.
So if we've got a diagnostic tool, some kind of test, we want to know what the usefulness of that test will be. So let's take a quick look at a hypothetical example. In terms of the entire population, some people have the disease, others don't. And in terms of the outcome of the test, some people will test positive and some people won't. So when we talk about sensitivity, we mean of all the people that are positive, the people that are circled in green, what proportion of those actually test positive? Those are the people that are circled in red. So it's a fraction, 66 over 70 gives you 0.94. Times it by 100 and you've got 94%. The test will identify 94% of the people that actually have the disease. The next thing we're going to talk about is specificity. We're interested in the population of people who are actually negative. Those are the ones that are encircled in green. And we want to know what proportion of those people test negative. Those that are encircled in red. So in this case, those encircled in red are the true negatives. So here we're saying 827 of the 830 will correctly test negative. So 827 over 830 is 0.99, which is 99%. So of people who don't have the disease, 99% of them will be correctly identified by this test. So I'm not going to go through all the calculations again for positive and negative predictive value. Basically, the exact same principle applies. The positive predictive value is the proportion of people who test positive who actually are positive. So the positive predictive value tells me if I go for a test and I test positive, what are the chances that I actually have the disease? Now, there's an important difference between sensitivity and specificity and positive and negative predictive values, and I need to explain this to you. When we look at the sensitivity test, for example, everybody in the green circle actually has the disease. And so the difference between the numerator and the denominator, the numerator being the 66 people and the denominator being the 66 plus 4, so the 70 people, the difference between those two groups is a function of the characteristics of the test itself, and it's not affected at all by the prevalence of the disease because everybody in that group has the disease. In other words, it doesn't matter if it's a common disease or not, because at that point in time, everybody that we're looking at actually has the disease. Now, this is not the case for positive and negative predictive values, because when we're looking at a positive or negative predictive value, the difference between the denominator and the numerator is affected by the prevalence of the disease in the community. And so it's not simply a function of the characteristic of the test itself. Now, this is still a useful test, but you need to remember that when you're comparing one test with another, in terms of the positive and negative predictive value, you need to be looking at the same population group, or at least population groups with the same incidence of disease.
Okay, so now you understand what the definitions of sensitivity and specificity are. You also know that ultrasound in general has a high diagnostic value, but that high value is dependent upon lots of clinically relevant influential factors which are very important for you to know. Let's have a look at them. The anatomy, which you're scanning, can affect the diagnostic accuracy due to a difference in complexity. In this slide, you can see a musculoskeletal ultrasound scan of the lumbar multifidus muscle. The level L4, L5 and S1 can be easily identified. Above these levels, you can see the multifidus muscle, and at the top, the thin, bright white thoracolumbar fascia. Measuring the multifidus muscle thickness is very easy due to its superficial position and the presence of a few clear landmarks. Scanning the temporomandibular joint and its disc kinematics during functional movements can be done, but it is much more complex and requires lots of experience. The temporomandibular joint is a closed joint. The presence of bones prevent a clear view on the soft tissue structures. The disc is small, and scanning the disc during movement is challenging. But it's not only the anatomy that can influence the diagnostic accuracy. Pathology can do this as well. Research into the diagnostic accuracy of ultrasound in detecting supraspinatus pathology has shown that some pathologies are harder to rule in and some are harder to rule out. With some pathologies, this is easier. For example, a full thickness tear is very easy to rule in and to rule out. But a supraspinatus partial tear, for example, is harder to rule in and easy to rule out. Meaning, if the tendon looks healthy, then you can assume that it's not a partial tear. But if the tendon does not look healthy, it's harder to specifically diagnose a certain disorder as a partial tear, and a tendinopathy can look quite similar. This slide uses the supraspinatus as an example, but please realise that this also applies to other anatomical structures. The high diagnostic value of musculoskeletal ultrasound is related to a few important criteria. We've already discussed two of the three patient-dependent criteria, the type of anatomy and pathology. The body composition is also an important factor. For example, the more subcutaneous fat a person has, the poorer the images. Scans made in the geriatric population are also of poorer quality due to the presence of degeneration and connective tissue changes. But if you scan two young people with the same good BMI, there might still be differences in image quality based on the different body compositions. The equipment you're using also affects the diagnostic accuracy. Make sure you buy good quality equipment that will serve your long-term musculoskeletal ultrasound goal. If you only wish to use ultrasound for biofeedback purposes, you can buy a different quality than if you're going to use the system for diagnostic or interventional purposes. We always suggest to first do a course in musculoskeletal ultrasound before buying an ultrasound system. Then you will learn much better what ultrasound is about, what kinds of quality there are, if you like it or not, and you know exactly what suits you and your practice the best. If you buy a system, make sure that it has at least the most commonly used functions. Ultrasound manufacturers constantly work on the software to improve the quality. A software update might be smart after a few years. More money buys more diagnostic accuracy, provided that the operator-dependent factors are optimal. These operator-dependent factors are numerous. Firstly, you need good education, which contains blended learning, a mix of hands-on practice and theory. More hands-on practice is always better. This is the reason we use an e-learning platform to make sure that you study the theory at home and you have more hands-on hours when you visit the course. Sonographers need to work in a standardised way and using existing protocols as a base to start scanning a certain joint. You will learn these protocols in the course. Using the protocols makes sure that you scan the absolute basics that is needed for a proper ultrasound assessment. In the next course levels, you will learn extra skills to become a more experienced sonographer. Knowing about artefacts is important. You will learn about these artefacts and their importance in another presentation. A lack of three-dimensional anatomy knowledge is a pitfall in ultrasound. Musculoskeletal ultrasound is looking at three-dimensional anatomy. The entry level of anatomy knowledge is sometimes poor, which leads to people not knowing or understanding what it is they're looking at. Experience has shown that a lot of people have difficulties with not only reproducing and understanding musculoskeletal anatomy, but also with its three-dimensional aspect. This is the reason why we promote doing cadaveric courses to study the three-dimensional aspect of anatomy. In our education, we use cadaveric specimens as much as possible in order to improve your learning. The best sonographers assess the patient with one hand holding and steering the transducer and the other hand on the ultrasound system. Every movement with the scanning hand leads to adjusting and optimizing the system's settings with the other hand. This leads to making quality images and more diagnostic accuracy. You will learn in 2 other presentations about the checklists you'll have to use while scanning. And last but not least, again, make sure you have lots of experience. The goal of this presentation is to show you some different images of supraspinatus pathology. An accurate diagnosis is not that simple due to the complexity of the anatomy and biomechanics of the human body. High-quality research shows that in plenty of cases, the diagnostic accuracy of the physical examination we do is limited. Currently, almost without exception, there is a lack of clarity with regard to whether common orthopaedic special tests used in physical examination are useful in differentially diagnosing pathologies. I can show you hundreds of different anatomical structures and even more pathologies, but let's keep it clear and simple. Let's just focus on a few normal, everyday pathologies of the supraspinatus tendon. On this slide, a healthy transverse supraspinatus is presented. Please memorise this picture. All patients in the cases you're going to see scored positive on 3 of the tests regarded as important supraspinatus physical examination tests: the NEAR test, the Hawkins-Kennedy test, and the empty can test. You will see that although these patients scored positively on all 3 examination tests, the musculoskeletal ultrasound images appear quite different. This is a right side, most likely partial tear of the supraspinatus, which has resulted in intratendinous swelling. Hence the darker hypoechoic colour and increased thickness of the tendon. The tendon is 9.8 millimetres. The normal average is around 5 to 7 millimetres. So in this case, there's a big increase in tendon thickness which influences the subacromial space, resulting in subacromial impingement. The left side shows an old partial tear, which seems to be repaired with fatty infiltration. This influences the loadability of the tendon and thus the training load or therapy that should be applied. The bursa seems to be chronically irritated and the glenohumeral capsule appears to be swollen. All these specifics are important for clinical reasoning and completing the ICF framework. Is the empty can test a test with good diagnostic accuracy, capable of revealing all these specifics? Unfortunately not. This patient had a lot of pain on both sides, left more than right. Big intratendinous calcifications can be seen. Of course, these calcifications are not the only cause of pain, but they certainly interfere with the treatment. Patients will ask you, how long will it take for the problem to heal? How sure are you about your answer? Maybe you rely on the connective tissue repair phases, but then you presume that the complaint can heal totally. This is a young professional tennis player. He is right-handed and for the last 2 years he's been having increasing problems with his service. The ultrasound scan shows a partial tear which with training will most likely heal in about 6 to 8 months. The changes of the humeral head, however, are definite. These will probably permanently affect the mobility. This is the shoulder, a left-right comparison of a 73-year-old tennis player. On the left you can see the asymptomatic side and on the right the painful symptomatic side. The right side shows a full thickness tear of the supraspinatus. The supraspinatus can't be seen anymore as it is already retracted. Apparently the full thickness supraspinatus tear happened a while ago, after which retraction followed. As a result, the humeral head has migrated proximally due to a loss of active stability. Here you can see a left-right comparison of a 35-year-old carpenter. On the left you can see the healthy asymptomatic side and on the right the affected side. The supraspinatus on the right shows an increased thickness and a darker colour compared to the left asymptomatic side. This could indicate tendon pathology, a tendinopathy or a partial tear. Musculoskeletal ultrasound can help in this decision making. Here you see the shoulder of a professional gymnast. After 3 months of training, a perfect supraspinatus quality can be seen on both sides. At the right side, a minor bursa sheath thickening can be seen. This results in a tiny amount of friction with the acromion on active shoulder abduction. The patient was given advice and some exercises and we stopped treatment. In the previous images, you could see how ultrasound is able to demonstrate the specifics of a pathology more so than a clinical examination test could ever show. These specifics are important for your clinical reasoning and your therapy choice. But in theory, all these patients could have been asymptomatic. The findings could have been false positives. So to exclude these false positives, you will have to include your clinical examination tests. These are needed to see if the ultrasound findings are really clinically relevant. And of course, all information from the ICF domain, body functions and body structures should be seen in the broader context.